But I want to go to the payer side of the
Right.
table in a way, because what's really interesting to me is you could argue that maybe there were those who recognized exactly what was going to happen, and they saw it with intent, because they want to consolidate the field. And we had medicine is the least consolidated industry, and which makes it really hard to manage when you have so many independent contractors literally taking care of patients. So do the payers look at it as, right now there's an increased cost, but in the long term it's going to be to our advantage because it will introduce the ability to create more control?
Well, there is a hugely increased cost on this, and what you're talking about, the consolidation that's driven, we know, and it's not just for oncology care. If the physician directing your care is a hospital employee, your total, as you look at that episode of care, you look at a PM cost, it's roughly 20 to 25% higher than if you had an independent physician, and that works across 1 million people in a patient-centered medical home. It works for primary care docs, and it's the same for oncologists, whether they're affiliated with that. I think you have similar numbers.
So is that kind of
huge.
Is that a new revelation? Because there were those who said that was going to happen back in 2005.
It happened.
But payers didn't increase community practice physician reimbursement, the 10 or 20% that might have kept them there. They seemed to sit back and watch all this happen. But now they're saying there's a huge cost. I mean, not to put you on the spot, you're only one company, but
Right.
but it seems like there's all of a sudden this, oh my God, look what's happened, when it seemed to be pretty predictable at the time, but no one was stepping up and changing physician reimbursement. The squeeze continued, especially after Medicare modernization.
I mean, the physician reimbursement is driven by Medicare, and I think, quite frankly, there's a lot of folks in Washington who like the consolidation that's happening in the clinical setting and feel that this is a better way to administer health care. You know, I think if some folks who are deciding policy had their druthers, they'd try to recreate Kaiser Permanente or the Mayo Clinic in every market, and even squeeze out health insurers and just have the consolidated institutions take over the provision of health insurance as well. We've tried that model in the 1990s. It didn't work with the PSOs. Most of them went bankrupt. A handful survived, but we're heading back in that direction. So, to your point, I think people look at this consolidation, whether it's being driven by 340B or other provisions that have been recently enacted. I think there's a lot of folks in policy positions who think that this is a preferred model for the delivery of healthcare.
And I just want to underscore, I mean, Scott said that very nice, he was very eloquent. I'll just get right to brass tacks. The bottom line is the current administration, and I'm a Connecticut independent, but the current administration literally wanted a single payer system. They couldn't get it in the ACA. And so this is the closest thing to backdooring it. So if you look at a number of initiatives, not only 340B, you look at in general reimbursement, they believe that the model of care is the Cleveland Clinic, Geisinger, these large, big, and they very much want to have the bigger get bigger. I mean, it's known. You come down to D.C. and as Scott knows, it's a known fact. So the problem is that we're seeing a number of factors that are causing consolidation, but both on the Medicare side, not just with oncology, and other areas of medicine, certainly on the private pay side, consolidation is costing. So how ironic is it that what is the ACA supposed to do? Really, what are they really the underpinning? Is to reduce costs. Yes, we'll make sure we take care of quality so we don't repeat the 90s, but we want to reduce costs. What are they doing? They're actually increasing
and let me just say,
costs in the
they're
process.
creating local healthcare monopolies, and we're getting into a bigger issue now, and that's going to ultimately drive up costs. Now, the question is, why are they doing this, right? And so I'll try to channel my inner administration official, even though I'm the sole Republican from Connecticut. But there's a perception that the way to lead to innovations in care that lead to better coordination of care is to have integrated delivery systems. So if you look at President Obama, literally every major speech he gave about healthcare had a mention of Kaiser, Geisinger, Mayo Clinic, or, one of those, Intermountain Health, one of those large integrated delivery systems. I think the problem with that is that there have been successful models for sure, but you're not going to be able to recreate that in every local market. Healthcare is very local. Markets are very local. They have different dynamics. And so I think we're going to find 5 years from now that we've created a lot of institutions that can't survive. If I was going to choose a business to be in right now, it would be in the business of helping distressed and bankrupt hospitals, because I think that's going to be a growth industry going forward.
Yeah. Well, actually.